Dr. Dalal Alhaqqan. She is a specialist in transplant hepatology, gastroenterology, and internal medicine at Mubarak Al Kabir Hospital, Ministry of Health in Kuwait. Dr. Alhaqqan graduated from Kuwait University, Faculty of Medicine in 2013. She completed her internal medicine residency at the University of Miami and holds the American Board of Internal Medicine certification. She then pursued a gastroenterology fellowship at MedStar Georgetown University Hospital and received the American Board of Internal Medicine certification in gastroenterology, and then went on to complete a transplant hepatology fellowship at the same institute, with anticipated board certification in transplant hepatology. Dr. Alhaqqan also holds a palliative care certification from Stanford University and a Lean Six Sigma certification in quality improvement. In 2022, she was honored with the Thomas Taylor Award at Georgetown University for excellence in teaching and patient care. Please join me in welcoming Dr. Dalal Alhaqqan. Dr. Dalal, the floor is yours.
Thank you so much for the kind introduction. Good morning, everyone. I'm just going to try to share my slides right now. Okay, are you able to see the slides?
Yes, doctor, it's clear.
Okay, perfect. Thank you. Good morning, everyone. Thank you again for the kind introduction, Dr. Lisa. I'd also like to thank the organizers for inviting me to give you a review of fatty liver, or as we now refer to it, metabolic dysfunction-associated liver disease, or MASLD. This is going to be the agenda for my talk today. First, we're going to talk a little bit about the new nomenclature, the change in the names, and then go over the epidemiology of MASLD, and then talk a little bit about the risk factors and to how to work it up and diagnose it. And then in the end, we'll talk about the management of MASLD in the primary care setting and go over some take-home points from this talk. All right, so the first thing that I want to go over here is my references, which is a little bit unusual. But my main references are two papers from the American Association for the Study of Liver Disease. They're both published in 2023. This first one was actually published later in the year in October of 2023. And this is the paper that actually changed the entire nomenclature for fatty liver disease, basically. And notice that it was published in October. The other paper by the AASLD, which was published earlier that year in January, was actually the practice guidance for non-alcoholic fatty liver disease. So this is actually using the old names. So if you actually read the guidelines from the AASLD and the next paper, which is the American Diabetes Association Disease Guidelines, they are still including the old names because the paper that changed all the names was released later in that year. So if you look at some of the tables that I'm using, that I'm adapting and showing from these papers, they're still using the old names, and that's why. So before we tackle the whole topic of fatty liver, we're going to go back to basics a little bit, just for a few slides. And this is just to get a better baseline of what the stages of liver disease are. So on the left, we start with the healthy liver. The first insult that happens is going to be fat deposition in the liver. You're not supposed to have any fat in the liver. So that's the first thing that happens that is not supposed to happen. Whenever you do have fat in the liver, this leads to irritation of the hepatocytes and then inflammation. And prolonged inflammation over time leads to scarring or fibrosis. And then whenever you have a big chunk of the liver that is affected with scarring and fibrosis, eventually it becomes irreversible. And whenever it becomes irreversible and the majority of the liver is affected, we call this cirrhosis. Now, this used to be my worst nightmare in medical school, histology, but I promise I tried to make it as simple as possible. We do think of two things histologically or at the level of pathophysiology when it comes to the mast cell. The first is steatosis, or the degree of fat that is in the liver. So this is divided into 4 stages, starting with S0, so no fat in the liver, and that's going to be your top left photo. And then the last one at the bottom is going to be grade 3, which is basically full of fat. So you can see all the adipocytes there. They're taking up the majority of the slide. And then in between, you have different grades. So grade 0, we said there's no fat in the liver. Grade 1 is less than 30% fat. Grade 2 is going to be between 1/3 and 2/3. And then grade 3 is more than 2/3 of the slide. And then the next thing that we think about histologically is fibrosis. So fibrosis is going to be divided into 5 stages. Stage 0, or F0, is there's no fibrosis in the liver. And then stage 5 is going to be, or F5 is going to be when there's complete cirrhosis. And in between, you have varying degrees of fibrosis in the liver. When you're looking at the slide, it's basically going to be the bluish discoloration. You're not supposed to be seeing that. The presence of that bluish color is basically an indicative of scar tissue or fibrosis. And the more blue you see, the worse it is. And then obviously when it starts becoming, when you start seeing bridging and they start to connect, meaning there's more scarring in the liver, that's when you start to have the cirrhosis process. So whenever I refer to having advanced fibrosis, I'm talking stage 2 or higher. So now that we have a basic understanding of the stages of mast cell, let's move on to understanding why the nomenclature was changed. So prior to the late 2023 in October, when they changed the terms, it was a bit confusing if you really think about it. First, it didn't really tell you much about the underlying etiology. So when you say fatty liver, it's just what it is right now. It doesn't tell you what's causing it or what the underlying pathophysiology of the disease is. And it also didn't sound very professional. So you're talking to a patient saying, oh, you just have a fatty liver. It doesn't really sound like a medical term. So it didn't sound very professional. So it needed to be changed. And then the most important thing, it's a very stigmatizing term. So using the word fatty, if you remember when we were kids in school, if somebody called you fatty or said you have something that's fatty, it was bullying, right? So it's not different when you're a doctor and telling a patient the same thing. The patient is going to feel ashamed or insulted or embarrassed. So all of these 3 reasons led to the change in the terminology. So now we use more professional sounding, less insulting terms to describe the condition. So in this slide, you can see kind of a visualization of the whole change in the nomenclature. Starting with the top, the umbrella term is now steatotic liver disease, or SLD. And then at the bottom, you have on the very left, the metabolic dysfunction associated steatotic liver disease, which is the topic of our talk, mast cell. And then under that, you can subdivide it into mast cell when there's just fat in the liver or steatosis without inflammation. And then it becomes MASH when there is inflammation in the liver. And then I'm going to skip over the middle one and go to the very the alcohol-associated one, because this is also now under the umbrella of steatotic liver disease, because alcohol also causes fat in the liver. So now that is called alcohol-related liver disease. And then in the middle, and this category is very prevalent in European countries and North America, and to a lesser degree here in the Middle East. You have the combination of both. So there are some patients that have mast cell and also have alcohol-associated liver disease. So they created a new category for those patients, and they called it MET-ALD, or metabolic alcohol-associated liver disease. And then as a subcategory of that, you can have patients that are not drinking as much and it's mast cell predominant, and then patients that may not be as overweight or obese or have risk factors, but they're drinking more. So the insult is more from the alcohol. And then we call it ALD predominant. And then in the gray, you have a specific etiology related SLD. So other diseases that can give you fat in the liver. These are going to be drug-induced liver injury, some genetic diseases, and other very specific and rare conditions. So what are the definitions? So mast cell is basically macrovesicular steatosis that involves at least 5% of hepatocytes. in the absence of other causes, such as alcohol, drugs, or genetic disorders. And in order to diagnose a patient with MASLD, you have to have hepatic steatosis, one or more cardiometabolic risk factors, and no other discernible cause of fat in the liver. And you also, if you remember the definition of the combined one, you have to exclude patients that consume a significant amount of alcohol, which is 20 grams in females and 30 grams in males per day. And then MASH is whenever you have MASLD, and then you also have active hepatocyte injury and inflammation. That's when we start calling it MASH instead of MASLD. So what are the cardiometabolic risk factors? So in adults, you need at least one out of these 5. The first one is going to be a BMI over 25, so 25 or higher, or if your waist circumference is more than 94 in males or 80 centimeters in females, or the ethnicity adjusted equivalent of those measurements. The second one is the fasting serum glucose of 5.6 or more, or 2-hour post-load glucose levels of 7.8 or more, or an A1C of 5.7 or more, or presence of type 2 diabetes, or being on treatment for type 2 diabetes already. The third category is having a blood pressure of 130 over 85 or more, or the patient's already diagnosed as having hypertension and has started on an antihypertensive drug. And then the final 2 are just criteria for elevated triglyceride levels or cholesterol levels. So any one of those is needed to make the diagnosis. So what about the epidemiology of MASLD? So what we know is that it's very prevalent. About 25 to 30% of the general population have it, but only about 5% of those that do have MASLD are aware that they have this diagnosis. So we're doing a really bad job at diagnosing these patients, and this is the area where we need to do the most work in identifying those patients. Unfortunately, I don't currently have data in Kuwait. We're still working on it. There is a study that we're planning to publish in early 2026 about the epidemiology in Kuwait. So I'm using the epidemiology in the US for right now. In the US, there's over 64 million people that are projected to have MASLD, and then the direct medical cost for that is about $103 billion per year, which is very significant. And we also know that the incidence is on the rise because it parallels the incidence of diabetes and obesity. And we think that by 2035, it's projected to double or triple in incidence, which is pretty bad. And then because I'm a transplant hepatologist, we're seeing a shift in the causes of liver transplant in the world. So it used to be more viral hepatitis and alcohol. Now it's actually MASLD and MASH being the #1 cause. So 60% of the patients that end up getting a liver transplant are because of fatty liver. And then what about epidemiology specifically in MASLD in type 2 diabetes? So the prevalence of MASLD in type 2 diabetes ranges anywhere from 34 to 94% globally. And amongst the patients that have MASH, 30 to 40% have advanced liver fibrosis at the time of presentation. And what's even more significant is 10 to 15% already have cirrhosis at the time that they're diagnosed. We do know that the mortality rate of diabetic patients due to cirrhosis is more than twice the general population. And patients that have both MASLD and type 2 diabetes generally have a poorer prognosis. So who is at increased risk? So persons with obesity or features of metabolic syndrome, obviously, and persons with prediabetes or type 2 diabetes, and anyone with hepatic steatosis that was noted on an imaging study that they got for a different reason or indication, or someone that has a persistently elevated plasma aminotransferase levels for over 6 months. So these are going to be kind of the high risk people. So now that we understand the nomenclature, epidemiology, and risk factors that are associated with the disease, let's move on to how to diagnose it and work it up. And starting with why is it important to diagnose and stage the disease? So it's very important to diagnose it and then stage it because the management is different depending on the stage. So in patients that have advanced fibrosis, it's different than someone that has mild fibrosis. So the degree of regression and how easy it is to treat them is different. When we talk about advanced fibrosis, F2 or F3, this is a stage where they have advanced disease, but there is a good chance that with the appropriate treatment, they can regress and go down to having mild fibrosis or even normal liver tissue. So up to that point, it's very reversible and regression is very feasible. But if you have someone that already has compensated cirrhosis at the time of the diagnosis, or F4, these patients can only be managed in a secondary care center. So they need to be seen by a gastroenterologist or hepatologist because they're going to require biannual screening for hepatocellular carcinoma because they develop it at a rate of 3% per year, which is a significant amount. They're also going to need to have endoscopy as part of surveillance for varices. And then we need to monitor them closely for decompensation, which occurs at a rate from 3 to 20% per year. So when it comes to diagnosis, the gold standard is going to be a liver biopsy because it provides both the grade and the stage of fibrosis. But obviously, not everybody needs a liver biopsy, and it's only a very small minority of patients that actually end up needing a liver biopsy to make the diagnosis. Obviously, because it's a very invasive procedure, there are risks associated with it. About 1 in 500 patients can bleed after a liver biopsy, and it can be a pretty significant and sometimes life-threatening bleed. And then even if you have an ideal situation, the biopsy itself can incorrectly stage the fibrosis about 20% of the time due to sampling, because you're taking a sample from a specific part of the liver and not the whole liver. And then a lot of times, some pathologists may have different grading for the sample. So if you show it to 2 different pathologists, you can get 2 different readings. But it is helpful in a certain minority and subset of patients. And these are the ones where you're really trying to diagnose a specific liver disease. Maybe the picture is not as clear and you want to know what the underlying etiology is. But also, and more importantly, this is when I use it more frequently, is when I have conflicting information. So if I do non-invasive testing and I get results that are completely different. So if I do an ultrasound and it shows me that the liver is cirrhotic appearing, and then I do a fibroscan and it says there's no fibrosis at all. So in this situation, in order to get down to the bottom of the case and know exactly what to do with the patient, I might send them to get a liver biopsy just to confirm or rule out. So basically, the most important kind of screening tool that you have at your disposal at the primary care setting is the FIB-4 score. This is the score that is used for risk stratification and to understand who needs to be further worked up or referred to see a gastroenterologist. If you look on the right, it has an explanation of what exactly, or the calculation that we use for the FIB-4 score. You don't actually need to do this. There are online calculators for you to use, and it takes less than a minute to actually punch all the numbers in and get a result. So you need the patient's age multiplied by the AST level divided by the platelet count and the root of ALT. And that will give you a number. So based on that number, if you get a number that's less than 1.3, then your patient is low risk. You can manage them in the primary care setting, and then you can reassess and redo the score every 2 to 3 years. If you get between 1.3 and 2.67, this is an intermediate risk, and this is when you want to start referring to a gastroenterologist. And then in that situation, if the patient just has MASL and doesn't have any evidence of inflammation or advanced fibrosis, we usually send them back to the primary care setting for further care. And then finally, if you get a score of 2.67 or above, these patients definitely need to be referred. And we usually tend to keep those patients because they tend to have more advanced disease. And then regardless of any fibrosis stage, it's always good to remember that from the beginning, these patients need to be referred to a MOVE program. This is something that we have in the US. I'm not sure if we have it here in Kuwait, but it's basically an exercise program for the patients to help them stay active and lose weight. And then management of their cardiovascular disease risk factors is very, very critical. And if they do drink alcohol, you have to ask them to abstain from drinking. And then the one that's usually forgotten about or ignored the most is making sure that their viral hepatitis immunizations are up to date. So if they haven't been vaccinated against hepatitis A, definitely give them the hepatitis A vaccine. And then double check their hepatitis B immunology and see if they need a booster or if they need to be vaccinated. So what are some other non-invasive testing that's available? So imaging, the abdominal ultrasound, the most common and cheapest one, CT scan or MRI. less common to just be ordered as the first screening test, but usually patients get them done for another reason, and then they pick up an abnormality in the liver, and then they end up being referred to us. But the most common and useful one is actually something called elastography. So this is a test that basically estimates the liver stiffness by applying mechanical waves and measuring their propagation. There are different ways of doing elastography. So it could just be an ultrasound, what we call a transient elastography, which is the more common one, which we refer to as a fibroscan. I'm sure you've heard about this one the most. And then there's different other modalities of ultrasound, like acoustic radiation force impulse, shear wave elastography, and then finally non-ultrasound elastography is MR elastography, which is the cool picture that I have here. And the different colors indicate the degree of stiffness in the liver. Since FibroScan is the most commonly available one and cheapest compared to the other tests, I'm going to be focusing on that, and that's the one that we actually have here available to us in the hospital. It's a very reliable test for the diagnosis of cirrhosis in patients with chronic liver disease. It's the most extensively studied imaging technique, and it has high intra and inter-observer reproducibility. It's very good at ruling in. So it's very good at ruling out than ruling in. So it's a good test to rule out cirrhosis, and it has a negative predictive value of 96%. The most important point is that the cutoffs for the values are different by diagnosis. So if I get numbers, I have to know what the indication for the test is. So on the referral, you have to say that this is for MASLD or fatty liver, or if it's for alcohol, or if it's for hepatitis B, because the interpretation of the results and the numbers is different based on the cause of the disease. And if you have a patient that already has a very high ALT level, so if you have a CMP and the ALT level is already like 300, 400, the test is not accurate, because the active inflammation right now to that degree can cause us to overestimate the amount of fibrosis in the liver. So generally, what I do is I refuse to do the test at this time, kind of manage the underlying problem. And then once the ALT starts coming down, I can get a better assessment with a FibroScan. So just going back, just telling you a little bit more about the FibroScan. As you can see in the bottom picture, the patients have to lay flat. So no pillow, nothing. So if we have a patient that is unable to lay flat on a bed, so patients with unoptimized heart failure that need to sleep on 2 pillows, or they have certain lung conditions or positional like back pain or musculoskeletal issues where they cannot lay flat, unfortunately, we cannot do this test. The other part is they have to actually be able to get up on the exam table. I did have issues with patients with like severe like obesity or severe lymphedema that are wheelchair bound, and it was very difficult to try to get them on the table. So in those settings, it's better to try to use alternative methods to check the elasticity of the liver. And then the more common one that causes problems is obesity. So the ultrasound probes that we use, so here in Mubarak Hospital, we have the medium and the large probes, and we can only, yes.
We just have 10 minutes left.
Okay. So here in Mubarak Hospital, we can only test patients up to a BMI of 40. So if you have someone that has a very high BMI, unfortunately, FibroScan is not the test to be done. So here's an example of what a test result for a FibroScan looks like. So the numbers that you're interested in are going to be the 2 numbers, the one in blue and the one in orange. So the first one, the one in blue, is the CAP score. This basically tells you how much fat or steatosis is in the liver. And so if you take the 293 and compare it to the table, that means it's S3. So this patient has 67% or more fat in the liver. And then the orange number is 10.4. So that's going to indicate how much fibrosis is in the liver. And that's going to depend on the etiology. So if you look at the table down there, if we take 10.4 in alcohol, that's F2, but 10.4 in fatty liver is actually F3. So that's why it matters to include the indication for the test. So what is the clinical approach for the whole thing? Just putting it all together. So this is actually just a little snippet from the ASLD algorithm, which I included in the next slide, the whole thing. But this is actually kind of the first step. So if the patient has elevated liver enzymes, then you have to start the workup to rule out other causes of elevated liver enzymes, such as hepatitis B, C. You can order autoimmune workup, iron studies, celiac, etc. And then you calculate their FIB score. And then once you ruled out all of the liver diseases based on their FIB-4 score, you can refer them to us. Or you can also order ultrasound and then get a FibroScan after you refer to us. So I don't have enough time, unfortunately, to go through this whole mast cell decision tree, but you can go through it at your own convenience. But it kind of incorporates the whole algorithm from the moment you meet the patient to exactly where they need to go. And then this is basically another slide on just how to interpret the FIB-4 score. So what do you do after you get the score testing? If they're low risk, less than 1.3, you can just keep following the patient and repeat it every 2 to 3 years. If it's more than 1.3, so you're going to have indeterminate risk or high risk, both of them, they need to be worked up with a transient elastography, or in some parts of the world, they have something called the ELF blood test. And then that will determine whether they are high risk or low risk. If it's low risk, we send them back to you, and then they repeat the testing in 2 to 3 years. If they are high risk, then they're going to be kept in our clinic, basically. So this is the management algorithm for, here it's NAFLD, but now it's MASLD. So if you have a high-risk group patient, such as a patient with prediabetes, type 2 diabetes, obesity, if they have cardiometabolic risk factors, or they already came with an ultrasound that showed steatosis or elevated liver enzymes, you're going to do a full history physical exam. You're going to rule out secondary causes. You're going to work on prevention of cardiovascular disease or prevention of cirrhosis as well by managing obesity, diabetes, hypertension, and dyslipidemia if they have it. And then you're going to risk stratify them to see if they need to come to us. And we do that with the FIB-4 score, the liver stiffness measurement by elastography. And then that kind of tells us where the patient ends up going. If they're low risk, back to primary care. And then you work on their risk factors and prevention. Or if they're indeterminate high risk, they're going to stay in our clinics. And then we're going to kind of have a multidisciplinary approach to that. Gonna skip this slide because this is basically just a summary of the previous algorithms, but put together. And go to the management. So management is very important. It's a multidisciplinary approach because most people with MASLD, they end up only receiving care from the primary care physician. So you are going to be the front line. You really have to have a high index of suspicion and be able to identify the appropriate persons at risk to screen. But once you appropriately do that and diagnose the patients, one of the most important steps is to actually educate them and counsel them on the nature and course of the disease and possible complications and how preventable they are at this stage. I think one of the more common things in Kuwait is that people truly underestimate what fatty liver is, and they just assume, oh, everybody has fatty liver, like everybody with diabetes has it. They don't really understand that the fatty liver is going to progress to cirrhosis at some point, and that this is completely avoidable with just some basic few steps that they can do at this stage. But by the time they have cirrhosis, then it's too late and we can't reverse that nature. So educating them that this is very preventable, and if you ignore it, it's going to be cirrhosis, and we're talking transplant and many complications. That will help the patients understand and kind of work hard at this stage to avoid all of these complications. Managing the metabolic comorbidities is a very essential part of the treatment because that's actually the underlying cause. So you have to address the root of the problem. And then the most important step at reversing MASLD is weight loss. It's easy to say that and harder to apply for the patients, but the goal is to achieve at least 5 to 10% weight loss over 1 year via healthy diet, regular exercise, and you can also refer them to see a dietitian or a psychologist if needed. And then patients with a really high BMI that meet criteria for surgery can be referred for surgery. Otherwise, we can use the newer modalities of weight management with pharmacologic therapies or endoscopic techniques that we have available to us. And then anyone with advanced fibrosis or cirrhosis needs to be followed up with a gastroenterologist, basically. So this is a slide to show how the multidisciplinary team is formed. So you have a primary care provider, endocrinologist. You're also going to have a nutritionist or lifestyle intervention with psychology if needed. And then weight management, either medically or interventionally, and management of lipids and cardiology if needed, and health psychology overall. And in the end, our role as gastroenterologists and hepatologists is for liver-directed therapies, identifying additional comorbidities, and then assessing the need for transplant if there is cirrhosis. So what are the pharmacotherapies? So if you have a patient, according to the ADA, that has diabetes with MASLD, you can use pioglitazone or a GLP-1 receptor agonist like liraglutide and semaglutide. In patients that have decompensated cirrhosis and diabetes, insulin is the way to go because there's little data on the safety of oral agents. And then in a subset of these patients with compensated cirrhosis, you can use semaglutide. Vitamin E, we used to use it in the past, but now there's more controversy because it can increase the risk of prostate cancer and cardiovascular disease. So we tend not to use it anymore as hepatologists. And I included a picture of a new medicine called resmetirom or Rezdiffra. And this medicine is very new. It was approved by the FDA 1 year ago. Unfortunately, not available in Kuwait yet. And this is targeted towards patients with advanced fibrosis, and it actually causes basically stops them from progressing to cirrhosis and can cause regression in about 30% of these patients. Like I said, it's still not available in Kuwait, and it costs about $50,000 a year. Hopefully, there are 3 more agents that are pending FDA approval. Once those are approved, the price is going to go down, and hopefully we'll have it available in Kuwait. And then obviously statins, the big problem is most people tend to stop statins. Doctors are scared to use them in patients that have cirrhosis. If the patient has compensated cirrhosis, you can use statins. Don't worry about it. In fact, it's going to actually help reduce the inflammation in MASH. And then obviously metabolic surgery by surgical team in patients that have both diabetes and MASH. So just the take-home points, MASLD is increasing in prevalence and incidence worldwide. Its incidence is projected to double or triple by 2035, which is very scary. Primary care physicians are the front line in identifying patients at the earlier stages of the disease and preventing progression and complications. And identifying patients at risk and screening them can help prevent progression to advanced fibrosis and cirrhosis and reduce the rate of future morbidity and mortality. Screen patients at risk using the FIB-4 calculator. And it's important to rule out other etiologies of liver disease, such as viral hepatitis. You have a lot of non-invasive tests available to you, serologic testing, as well as imaging like elastography. The gold standard is a liver biopsy, but this is rarely needed to make the diagnosis. And the management involves a multidisciplinary team, includes education, counseling, providing patients with resources, emphasis on lifestyle changes, including dietary modifications, regular exercise, and their goal is to lose 5 to 10% of their weight over 1 year. And the use of pharmacologic therapies to control comorbidities as well as to aid weight loss if indicated. If they need referral to surgery or endoscopic procedure, go ahead and do that, and then refer them to us to GI or hepatology if they have advanced fibrosis or cirrhosis. Thank you. I included my email if anyone wants to contact me or has any questions, but I'm happy to take some questions if I have some time right now.
All right. Thank you very much for the informative lecture, Dr. Dalal. We just have a few questions. So the first question is, when do we stop statins?
So actually, you don't stop statins. If they're on statins or they need them, please start them on statins. Statins have anti-inflammatory effects on the liver. So you really need them to help control the disease. The only time I would consider stopping statins is if the patient develops decompensated cirrhosis. So at that stage, they probably won't even be in your clinic. They're going to be seeing me in my clinic. So I'm the one that will decide to stop the statins. But up until that point, do not stop the statins. In fact, look for indications to start statins. I think probably in the next 5 to 10 years, we might see some data where even patients that don't have hyperlipidemia might benefit from being started on a lower dose statin just to treat the MASH. But again, that's not a guideline right now, but in the future it might be, and I predict that it will be, but do not be scared of statins and liver disease.
All right. So another question is, all patients with fatty liver and ultrasound need to do fibroscan?
No. So this is a good question, actually, because it sometimes annoys me a little bit when I get referrals for that. So whenever you do a regular or order a regular ultrasound, what they see with the regular ultrasound probe as fatty doesn't necessarily mean that there is fat in the liver per se. Any cause that causes acute elevation in the liver enzymes. So for example, if you have a flare of autoimmune hepatitis, or if you have an acute viral hepatitis B infection or viral hepatitis A, because there's so much inflammation, when you put the probe, it looks like fat, but really it's not fat. If you repeat it after treatment, it goes away. So that's why it can be used as an initial screening, but it doesn't actually mean anything without confirmation using elastography or other modalities.
All right. And can we start treatment if patient has FIB-1 score? If yes, can we switch his meds, especially if patient is diabetic?
What treatment are they referring to?
Can you please, whoever wrote the question, can you please elaborate exactly what treatment you mean?
So if you're referring to statins, yes. I don't really stop statins. I encourage the use of statins at any stage except decompensated cirrhosis. If you're referring to specific treatments like there is Diffra, the newer medication that's fluoromaceled, this is right now reserved for patients that have advanced fibrosis, but I'm sure in the future it's going to expand. But anyone with a lower score that's low risk, you're still going to treat as prevention, right? So if they're diabetic, if they're overweight, if they have hypertension, if they have other risk factors, you're going to manage them aggressively to prevent progression or development of the disease in the future. So I hope I answered the question, even though I didn't understand what treatment you're referring to. But if you can clarify, I'm happy to answer that as well in the chat.
We have another question. Thank you, Dr. Dalal, the best gastroenterologist. There is any specific diet recommended to MASH?
So one particular diet, no. It's basically anything that works for the patient. The American guidelines do mention the Mediterranean diet as one of the possible options. But at the end of the day, whatever diet that is going to be low fat, low carb, that's going to actually help the patient achieving the weight loss is what we recommend.
All right. So we got, for our previous question, we got clarification. She means pioglitazone or GLP-1 receptor agonist, even if the patient is still FIB-1 score.
Oh, okay. So the pioglitazone and the GLP-1 agonists, you're gonna, if they have an indication to use them as part of their original disease, like diabetes, sure, you can use it. But if they're not on it and they have MASH, you can use it as an add-on. This is depending on the stage. So if they're early stage, low risk, they don't have MASLD, if they have another indication for it, which is the underlying disease, the diabetes, and you want to use pioglitazone, sure, that's fine. But the recommendation from the ADA is specifically for patients that do have MASH and diabetes. So that's when you want to start using the pioglitazone.
All right. And does FIB-4 applicate in age less than 35, or does age doesn't really matter as long as the risk factors are there?
So yeah, age matters. Between 35 and 65 is usually when it's more validated. So younger than 35, I probably would not use the FIB-4 score. You can use other scoring methods and risk stratification methods, but it's only really been validated above 35 and below 65.
All right, any more questions? Okay, it seems like we don't have any more questions.
Thank you.
I would like to thank, on the behalf of everyone, Dr. Dalal, sincerely for her lovely and insightful and informative presentation. We truly appreciate your time and expertise you've shared with us today, and looking forward to meeting you again in future events. So now we will be having our break, and we'll be back at